In this last lecture video from Unit 3, we're going to be talking about autoantibodies and autoimmune hemolytic anemia. So we'll start with just a little bit of terminology. Autoantibodies, which we've already mentioned previously, it's when a patient has antibodies to self-antigens. So they've somehow developed antibodies to antigens that they possess. Alloantibodies are antibodies to foreign antigens, so these are stimulated by either transfusion or pregnancy. Idiopathic, the term idiopathic pertains to a condition without a disease or any type of recognizable cause, so it's a disease or condition that seems to have spontaneous origin. And then autoimmune hemolytic anemia is immune destruction of autologous red cells. And again, auto means self, so destruction of your own red cells. Okay, and interpretation of a positive DAT result as a clue to autoimmune hemolytic anemia. So if the positive DAT is associated with a transfusion reaction, then it's going to be of IgG specificity, so it will be a specific allo antibody that we're having reactivity to. In the case of warm autoimmune disease, it could be either IgG or complement. So it's going to react, you're going to see reactivity with all cells at the AHG phase of testing. Cold autoimmune disease or pneumonia is going to be due to complement, so you're going to see reactivity with all of the cells at colder temperatures. If it's due to a drug reaction, again, it could be IgG or complement. A serum may be non-reactive. If you've got a clot tube stored at 4 degrees Celsius, it's going to be due to complement. You won't see any reactivity with the serum. And then if it's due to hemolytic disease of the fetus and newborn, where you've got maternal antibodies on the infant's red cells, this is going to be due to IgG. So this is an allo antibody from the mom on the baby's red cells. Okay, cold antibodies and cold autoimmune hemolytic anemia is caused by IgM antibodies. So those are our colder reacting antibodies. So they're going to react optimally at temperatures below 37 degrees Celsius or below body temperature. So reactions in testing at room temperature, this is going to be your clue to recognizing a cold auto antibody. Cold agglutinin disease. So the patient may have a history of mild anemia, may have a history of Mycoplasma pneumoniae infection or infectious mono. The chronic form of cold agglutinin disease can be seen in elderly patients with lymphoma, CLL, or Waldenstrom's macroglobulinemia. The EDTA sample might appear agglutinated or clotted at room temperature. In vivo, the cold autoantibodies can bind cells in the colder parts of the body, so like fingers, nose, toes, and ears, so those extremities that tend to stay a little bit colder. And when this happens, it can initiate the complement cascade. So antibodies dissociate from the patient's cells, and then once they're returned to warmer parts of the body, excuse me, but that complement cascade has already been initiated. So you've got that antigen antibody binding reaction that's going to continue. So the antibody specificity in patients with cold agglutinin disease is usually going to be anti-big I, less commonly anti-little I. Okay, paroxysmal cold hemoglobinuria. This is a rare autoimmune disorder with hemolysis. The patients will display hemolysis and hematuria when the patients are exposed to cold temperatures. With anti-P, with this immune hemolytic anemia, this is IgG that reacts weakly, if at all, during in vitro testing. And then anti-PR is an antibody that can also be implicated in cases of paroxysmal cold hemoglobinuria. This can appear transiently in children after viral infections and in adults with tertiary syphilis. So we mentioned that previously in it was a previous lecture. The Donath-Landsteiner test is required for confirmation. And the patients may have a weak positive DAT reaction, and that's just due to the complement coating. P negative blood is not required for transfusion, but units should go through a blood warmer, and patients should always be kept warm because it's in those colder temperatures that we're going to see reactivity. Okay, paroxysmal nocturnal hemoglobinuria. So this a lot of times will be confused with paroxysmal cold hemoglobinuria, but it's an autoantibody. An autoantibody has not been implicated in nocturnal hemoglobinuria. They think it's due to an intrinsic defect in the red cell membrane, which renders it more susceptible to hemolysis in an acidic environment. So this condition is characterized by blood in the urine following periods of sleep. So if a patient has been asleep for a while, gets up to urinate, and then there's blood noticed in the urine. PNH is complement mediated because of the absence or reduced amounts of some complement regulatory proteins. Okay, hemolytic disease of the fetus and newborn. In this condition, you've got mother's IgG antibody that is causing destruction of fetal red cells. ABO antibodies are most common, but Rh antibodies is where you'll see the most severe reactions. So this happens when mom makes antibodies to red cell antigens, to the baby's red cell antigens from exposure through transfusions or prior pregnancies. So in the case of ABO HDFN, you've got a type O mom who has either an A1 or a B baby. This can affect the first child. Anti-A, B is an IgG antibody. There might be some anti-A and some anti-B, both of which are also IgG, but these antigens are not well developed at birth. In the case of Rh, HDFN, you've got an Rh negative mom and an Rh positive baby. So anti-D, which the mom is going to produce in response because she's D negative, baby is D positive, anti-D can cross the placental barrier. So what happens is mom gets exposed, if mom is Rh negative and gets exposed to the first Rh positive baby, this is when she starts building antibodies. So the first child rarely demonstrates any clinical signs of HDFN. It's when subsequent pregnancies with Rh positive babies where we start to see the more severe reactions, because mom has already developed that antibody, anti-D, after the first child, and so any subsequent pregnancies with Rh positive babies, that anti-D can attack the baby cells. The Rh antigens are well developed at birth. So again, these are antibodies that are directed against fetal antigens. They cross the placenta, they sensitize those fetal red cells, and they're going to shorten red cell survival. So this results in a disease that can vary anywhere from anemia to fetal death in utero. It causes something called kernicterus, which is also referred to sometimes as bilirubin on the brain. It's a rare kind of preventable brain damage that happens with jaundice. And then indirect bilirubin is going to be increased. You'll see an increased retic count. You're going to see a lot of NRBCs on the diff, and this is in the baby's sample. So with your lab testing. So for mom, she's going to get an ABO, RH, and an antibody screen or an IAT. And there'll be a determination of a feto-maternal bleed. This is done with the screening test is called the Rosette test. So you've got maternal red cells that are going to have that are D negative maternal red cells, and a small number of D positive fetal red cells. So you've got this mom's sample incubated with anti-D. During incubation, anti-D reagent is going to bind with the D positive fetal cells. Then we have to add indicator cells, which are just another reagent. They're going to attach to the anti-D and form rosettes. So this is a qualitative test. So we just report it out as positive or negative, but a positive result indicates a bleed of at least 10 mLs. And again, we're looking at this reactivity. We're looking for those rosettes under the microscope. So the method to quantitate the bleed is called the Kleihauer-Betke test. So that's what we would follow up a positive rosette test with. So in the Kleihauer-Betke test, you've got 2,000 cells that are counted to determine the percentage of fetal cells that are present. This is an acid elution method. So you're comparing adult cells to fetal cells. So if the bleed is found to be over 30 mLs, then the patient would need an additional dose of RhoGAM. Okay, so what is RhoGAM? RhoGAM, or which is kind of the commercial name for it, or RH immune globulin. So this is commercially available gamma globulin consisting of high titered anti-D. We use it to prevent alloimmunization to the D antigen. So it suppresses the immune response after exposure to D positive fetal red cells, prevents mom from producing anti-D. So RhoGAM is used prophylactically during pregnancy. So if mom's type is done and she is found to be RH negative, she is going to be administered RhoGAM during her pregnancy, usually between 26 to 28 weeks. And then also postnatally, so within 72 hours of birth, miscarriage, or abortion. So, and this is going to go for all RH negative moms. And the point is, if the baby is Rh positive. So if this is prior to birth, we're not going to know if the baby is Rh positive. So we're going to administer the RhoGAM during pregnancy, and then just to prevent that reactivity. But then after the baby is born, we do the blood type on the baby also. And so if the baby is positive, mom's going to get an additional dose of RhoGAM. If baby is Rh negative, then no additional dose is needed. One dose or one shot is 300 micrograms of RhoGAM. It provides protection for up to 15 mLs of D positive cells. And again, that's determined by the Rosette test. Okay, testing on the baby. So after baby's born, we're going to do an ABO forward and RH. We don't do reverse testing on babies because they're not going to have antibodies yet. And then we also do a DAT test on the baby. So the testing is done on the cord blood, which has to be washed 4 times before testing to get rid of the residual Wharton's jelly. So it's just a type of protein that's on the cord blood, so we have to wash it, do an extra wash step just to get rid of all of that protein that could interfere with our testing. Okay, exchange transfusion. So in this process, we're slowly removing the patient's blood as they are being transfused with donor blood. Phototherapy is going to be the initial treatment for hyperbilirubinemia. So, and that's because when bilirubin is exposed to light, it breaks down. Cases of hyperbilirubinemia that do not respond to phototherapy may have to resort to exchange transfusion to reduce those bilirubin levels to prevent kernicterus after delivery. So exchange transfusion involves replacing 1 to 2 whole blood volumes to accomplish the following. So we're trying to correct anemia without expanding the blood volume. So that's why we're taking out or putting back in what we're taking out. It removes a sensitized newborn's red cells and replaces it with antigen negative cells. It reduces the level of bilirubin to prevent kernicterus, which those high levels of bilirubin on the brain can cause neural symptoms related to the elevated bilirubin levels. And then the exchange transfusion also helps to reduce levels of maternal antibody that might be present. So the donor unit has to be, if we're transfusing a baby, it has to be CMV negative and irradiated since the baby is immune compromised. It has to be hemoglobin S negative to reduce the possibility of intravascular sickling, less than 7 days old. It has to be ABO compatible with mom and baby, and the unit has to be reconstituted with FFP or fresh frozen plasma to a hematocrit between 45 and 60% in order to restore the albumin and coag factors. Okay, dealing with cold autoantibodies. So one of the first tools that we can use to confirm the presence of a cold autoantibody is doing a cold panel. So we've got a set of selected reagent red cells with our most common cold specificity. So that's usually going to be anti-big I, anti-H, and anti-HI. Okay, so after we confirm the presence of a cold autoantibody, we want to try to avoid reactivity because, again, the cold antibodies and autoantibodies really just cause more. They're not necessarily clinically significant when we're talking about transfusions, but they can be significant when we're during testing. They can just kind of mess up our test reactions. So we want to use IgG antiglobulin reagent in the AHG phase instead of polyspecific reagent, which does not detect complement attachment. It eliminate the initial spin and the 37 degree Celsius reading. So if we know that these reactions are only going to occur at initial spin and maybe 37, and we also know that they're not clinically significant, they're only going to mess up our testing, we can just kind of avoid those phases of testing. We want to avoid methods that enhance these reactions. So PEG, enzyme, solid phase can all enhance cold reactivity, so we want to either use LIS or tube methods instead. We can do a pre-warm technique. So we want to pre-warm the serum and cell suspensions to 37 degrees in separate tubes to prevent this antibody attachment occurring at or below room temperature. You have to be careful when you're using this method because it can reduce the chance of recovering weak, clinically significant antibodies. You could treat the plasma with 0.2 molar DTT, dithiothiol, which is referred to as a thiol reagent. It dissolves IgM antibody disulfide bonds and eliminates activity of the antibody. IgG antibodies are usually not going to be affected. And then absorption techniques. So in rare instances, absorption may be necessary for cold autoantibody detection of an underlying clinically significant alloantibody if that cold antibody persists. So with absorption, you've got attachment of the patient's antibodies to the patient's own red cells and subsequent removal from the serum. So we're kind of getting them out of the way so that we can continue with the testing to find our clinically significant antibody. Autoabsorption can be performed if the patient has not been transfused in the past 3 months. Rabbit erythrocyte stroma or allogenic red cells can be used if the patient has been transfused in the past 3 months. And then once the cold antibody is absorbed, the adsorbed serum can be retested with a panel to determine if there are underlying allo antibodies present. And then at that point, you could continue on with the identification of any allo antibodies that might be present. A lot of times, adsorption techniques are going to be send out tests. So if you kind of do all the testing that you can on your patient sample to determine the antibody ID and you can't get to a definite conclusion, you can send that sample out, and then other, like your reference labs may have additional techniques like the adsorption or different reagents and whatnot that they can use to test. Okay, warm autoantibodies and warm autoimmune hemolytic anemia. So just some general information. These conditions can be idiopathic. They can be part of a pathologic disorder, or they could be caused by medications that are used to treat different diseases. IgG antibody, these are going to be IgG antibodies that react best at 37 degrees in vivo. So the antibody coats the patient's red cells, and if the level is high enough, the cells become saturated with antibodies, leaving excess antibodies circulating in the plasma. You would see pan-agglutination in the screen, in the identification, and in the cross-match at IAT phases. So pan-agglutination just means that you're going to see reactivity in almost every cell, if not every cell. Patients might have a positive DAT with IgG antibodies only, or with a combination of IgG and C3d. Some might have a negative DAT. So the patient's diagnosis, their medication history, their transfusion history, all of those factors can be important to help with identification of the antibody and in an approach to a resolution. Okay, specificity. Sometimes these warm autoimmune hemolytic reactions are going to be directed to the Rh system, especially the little e antigens. So the patient's serum appears to have an anti-little e, even though cells are E positive and have a positive DAT. Testing with E negative panels can help determine the specificity. And then you would have to cross-match for E negative donor units to be used for transfusion. So some methods for dealing with warm autoantibodies, you could do an elution. So in cases of warm autoimmune hemolytic anemia, it can be helpful to identify the specificity of the IgG antibody to the patient's red cell when the DAT is positive. So to identify the IgG attached to the red cells has to be removed from the cells. So the procedure of dissociating the antibody from the red cell into a solution for additional specificity testing, that procedure is called an elution. That recovered antibody in the solution is called the eluate. This technique is not helpful if it's only complement that's attached to the red cell. This can also be used for identification of the antibodies that could be causing hemolytic disease of the fetus and newborn. So the eluate is prepared from the newborn's red cells and demonstrate an antibody passed to the infant by the mother during pregnancy. Here is a table that shows some of the different methods of elution that can be done, how the mechanism that they're working by, and then benefits and limitations. So just read over those comments there. Okay, and then adsorption, again, with warm autoimmune hemolytic anemia. So this might be necessary if there's an underlying autoantibody that needs to be identified. It cannot be done if the patient has been transfused within the past 3 months, because those transfused red cells might exist in the patient's circulation and may absorb the alloantibody that we need for identification. So the goal is to remove the autoantibody from the serum so that any underlying alloantibodies can be identified, since the pan-agglutination nature of warm antibodies can mask other antibodies. So you've got autologous red cells in circulation that are coated with autoantibody. So you might do an initial pre-treatment with DTT that removes a lot of the in vivo attached antibodies. So as those antigen sites on the red cells are uncovered, free antibody will bind, so that facilitates your serum antibody removal. Treating your cells with enzymes like papain or physin can also help to increase the capacity of the cells to attach more antibodies. After red cell treatment, the patient's serum and the patient's red cells are combined. They get incubated for between 30 and 60 minutes to remove the non-specific warm antibody. And then after removal of the serum from the cells, the adsorbed serum is retested with reagent red cells to detect and identify any underlying alloantibody. For patients who have been transfused in the past 3 months, a differential or allogenic adsorption aids in the detection of any possible underlying antibodies. So this uses known red cell types that match the patient's phenotypes or represent a combination of antigens selected to remove certain antibody specificities. So your enzyme treatments might enhance the uptake. So after incubation, your adsorbed serum is removed and it's retested again against the screening or the panel cells to determine if there is an underlying alloantibody. And then to phenotype red cells in patients with warm autoimmune hemolytic anemia, treatment with chloroquine diphosphate or an EDTA glycine hydrochloride solution might be required before we can antigen type. That's just to remove that IgG from the cell. So you've got antibody attached to the red cell has to be removed for that testing to be valid. And again, also check the patient's history. If transfused cells are still circulating, antigen typing might not be accurate. For drug-induced autoantibodies, so there's sometimes some medications can induce the formation of autoantibodies and might cause serologic manifestations that look similar to an autoimmune disease. But these are classified as drug dependent and drug independent. So that depends on if there's interference that's detected during our serology testing. So drug dependent, you've got a DAT that will be positive, but the serum is non-reactive with the screen and panel cells. So reactions occur in vitro only when the drug is added to the test. So drug independent, you've still got a positive DAT reaction, but the screen and panel cells are positive and resemble a warm autoantibody in vitro. And these are things that we don't really see that often. So if you do encounter something like a drug-induced autoantibody, you would have to do additional testing and look at the patient's history to determine if that's what it is. And then we'll get into some additional testing that can be performed in the next unit to resolve some of these issues.